Before we get started, just a quick word from World Extreme Medicine. If you work in pre-hospital, remote, expedition, humanitarian or high-risk environments, World Extreme Medicine exists for one reason: to help you deliver safe, effective care where resources are limited, decisions matter, and help is a long way off. From expedition and wilderness medicine to hostile environments, dive medicine, leadership, and human performance under pressure, World Extreme Medicine bring together clinicians and operators with real-world experience in some of the most challenging settings on the planet. Their courses, webinars, and global faculty are built around practical decision-making, not just theory, to focus really on what actually works when things go wrong, far from definitive care. To find out more and explore upcoming courses and indeed educational content, visit worldextrememedicine.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're diving into the psychology and practice of performance under pressure, exploring how we can prepare clinicians not just to survive stress, but really to thrive within it. So joining me once again is Andy Bell, Deputy Director of Paramedicine at St John WA. He's a leading voice in clinical education, leadership and performance optimization. So today we're going to explore how stress inoculation training, cognitive load theory, and indeed deliberate practice can transform the way we teach, lead, and perform in high-stakes environments. So we're going to unpack why maybe the traditional idea of resilience may be holding us back, and how entrenched paradigms limit performance, and how really flipping the script on stress can build more adaptive, confident clinicians. So from the science of threat versus challenge mindsets to the power of realistic simulation and indeed reflective education, this episode offers practical insights for anyone working on the front line of emergency care. Andy, welcome to the podcast.
Hey mate, thanks for having me. Nice to be back.
Now, I just wondered, as we start, Andy, could I just kick off by broaching one of the main topics really, which has been bandied about quite frequently actually, around cognitive resilience, and just flipping the script on resilience and actually what we really mean by embodying resilience, and maybe how we can move beyond the simple idea of coping with stress to truly, well, in a way, preparing for it.
I'm gonna open up with a little quote from actually a good friend of mine, Lee Anderson. Lee is a paramedic here in Australia, and he recently published a book called The Paramedic Mindset, which is a brilliant piece of work where he's drawn together a lot of these theories and stuff. And he and I spent many hours on the back deck at my place in Brisbane, over a couple of cold beers, discussing some of these concepts. And his definition of resilience, I think, really resonates. And so it's a dynamic process encompassing positive adaptation within the context of significant adversity. And when you unpick that and when you unpack that, what you see is that it's a process that, by being dynamic, means it's constantly changing. There's no such thing as an endpoint in resilience. You don't become resilient and then never have to do more work, right? That's not how it works. And in fact, you can be resilient in one area and be really not in another. And so, although there are certain mindsets and skills and things that you can learn that will then help you to become more resilient across the board, but what it means is that there is a context that needs to be applied. And we all know that there are people, for example, that might be particularly good at managing stress in one particular type of environment and not good in another. We see this in some high-performing sports people who do very well managing stress on, say, the sports field, but their personal lives, sometimes things don't go quite to plan. And so it's not, are they applying these lessons across like the breadth of their understanding, or are they only able to put it into these very small sort of narrow niche contexts? So for the other part of that definition to really resonate, it's that adaptive part. Like what we're talking about is mind is muscle. You know, your mind is a muscle. If you don't work it, it won't change. If it doesn't change, you won't get any kind of like increase or decrease in a thing. So therefore, you have to really understand that the thing you're doing for a purpose. And in order to do that, you then have to have some kind of goal set, etc. So all of this is, I guess this all very, very clearly is, it's process driven. There is no like two dot points. There's just a whole series of things in between, and you're all, along on the ride or on for the journey. And so, from my mind, when we are looking to develop resilience, particularly if we now put it into the clinical context, we have to ensure that we are giving the people that we want to build the resilience the opportunity to operate in that context and then be guided to adapt in that context. And that's going to mean things like applying and giving them appropriate systems. It's going to be able to mean that we have to give them appropriate support structures. And it means that we're going to be able to, or have to be able to, give them the opportunity to be able to both fail and to succeed. And when you start kind of putting all that in the mix, then you start to get this idea of resilience, right?
Yeah, no, indeed, indeed. And I think one of the things, like you said, it's adaptive, and it's also it's a skill which is learnt over time, and it indeed is evolving. And there's also, it's also a spectrum, isn't it? And I really want to just chat to you now really about that spectrum, because it's when you think you're resilient, and you know this, Andy, the job is a great leveler, and it's great at knocking a few chips off your ego when you think, gosh, I'm resilient, I'm experienced, I can do this, and then the next incident you go to just completely untethers you and undoes you in every which way, because the human factors on scene, or the stressors, or indeed the clinical demands. So I guess in a way you're absolutely right, and it is adaptive in a dynamic environment, and we embody dynamic environments every day as pre-hospital clinicians, and have to adapt to those, and optimize and come to a safe baseline. One of the things I really loved, Andy, about working at London HEMS, it was the concept was they could take the worst doctor. This was one of the sayings. It was really, we can take the worst doctor and the worst paramedic on the worst day and the worst shift, and still come to a predefined outcome, so that the system that you train in can actually take the worst day, the worst team, and still end up being, a safe system. And I really like that, because what you're trying to do is come to some appropriation of baseline. But Andy, could I get to speak to really just the other end of that, when the wheels start to fall off? How we can better recognize that kind of, we are losing control, that early psychological and cognitive signs of stress, where we're losing. We can just, because I think it's a real interplay where I can start to say, look, my bandwidth is full. I'm either doing laryngoscopy. I can't do anything else. Please take care of the scene. Or the whole scene is getting kind of, I just need to offload and delegate. Could I just get you to speak to that awareness of when it's right to really kind of offload and pivot?
Mm. There's a lot there. So, one of my, and you and I have spoken about this, off air. One of my favorite authors, and certainly people in this space, is a guy called Gilbert Inoka. Gilbert is a psychologist, and has worked with a lot of the top teams and people in the world. He's very famous for his work with the All Blacks, and he talks about training messy. Like, we talk about, oh, you should train to be good, or you should train to be perfect. And he's like, well, actually, no, because it's not possible. It's not possible to be perfect. And if we are only aspiring to be perfect, then we will always fail. You will constantly fail. But if you train messy, you train to fail, or you train for things to not be perfect, but then still succeed. Now that's a mindset shift that allows you to go, okay, I'm heading in this direction. I'm not exactly sure how I'm going to get to where I need to get to, but I have these tools in front of me, whether or not they're, hard skill, technical skills, whether or not that are more of a soft skill, non-technical skill type, whatever. These are the things I have in my toolkit that are going to aid me to get to the outcome that I'm aiming for. And it's okay that it's not going to be perfect along the way. I think that's a really, really cool little mindset shift. And it doesn't sound like much, but it actually makes a massive difference. And then we can talk about like the physiological impact, can't we? We can talk about hypersympathetic response. We've all felt it. The heart rate goes up, the respiratory rate goes up, the face flushes, we start to sweat, all of those things. We've all been there. Now, those things are physical manifestations of a psychological response. We have already psychologically responded if we are already doing those other things, right? And so the key to that then is to recognize, because you can't stop it, right? You can't stop a response that is designed to be there. We need a sympathetic response. That's how we adapted as human beings. Otherwise, we would have all got eaten by the saber-toothed tiger back in the day. We would have never run away, right? Because we were all so cool about it. The difference is that we need to be acutely aware that we are doing it. And so that's what we need to do. We need to train for a understanding of how we will respond when we are stressed. Because you can't remove stress. And in fact, we don't want to move all, if you removed all stresses, we'd just be potatoes, right? We wouldn't do anything. So we need that stress. You can talk about Yerkes-Dodson, you can talk about inverted U theory and optimum arousal and all those kinds of things. But really what we know is we need a level of stress. And in some roles, particularly ones like ours, there will be an innate level of stress that is probably higher, certainly in certain situations, than is normal. That's not, you cannot eliminate that risk. So you have to mitigate it. And the mitigation of it is an understanding of one, the recognition that you are stressed, and two, what you have in your toolkit to then manage that stress response. And that's when we can start to look at things like your level of your training, the systems that you operate in, and then you can even go down into more nuanced things like, how are you managing your breathing? Are you doing some kind of psychological mental preparation and that sort of stuff as well? So yeah, there's a whole bunch there.
Yeah, absolutely. No, absolutely, Andy. And just pivoting and looking at really some maybe unhelpful mindsets that don't necessarily help us with managing stress, or indeed just around outdated beliefs, really. In high pressure environments, the old adage of keep calm and carry on is is cliche, but it doesn't really help. Understanding, like you said, just the finite short-term memory can plus or minus seven. Seven. Don't overload the short-term memory or other people's short-term memory. Learn to delegate, utilize the room, use names. Just constantly delegate and unfill your mental bucket so that you are able to stand back. Learn the art of stepping in and stepping back as a leader, understanding, like you said, your own part of this is just know thyself, understand yourself, understand when you're becoming overwhelmed, so you can step back, you can delegate, then step back in. But all that is a journey. But could I get you to speak to really, I guess, in a way, just some unhelpful, outdated beliefs that maybe still dominate
Mm.
in this space?
I'm probably going to screw this up, but Bernard Shaw said something like, progress is impossible without change. And so those that can't change their mind can't ever progress, or something to that effect. But you get the gist, right? So that is the problem. The problem is that in order for us to evolve, in order for us to progress in any way, then we need to have the ability to be able to change. Well, change means we need to be able to look at something in a different way and then adapt to that change, to that different way of perception or whatever. So, there's those old adages of like the fixed mindset, growth mindset concepts and things like that. And they are very much true. We can also then buy into the idea of biases. We've all got them. Anyone who says they doesn't has the third bias, which is the I don't have a bias, which is one of my favorite. Confirmation bias, desirability bias, the things that make us, because we want to be right all the time. That's just that human nature takes over. We need to become cognitively aware of those things because, again, if we're not aware, then you can't or you don't know what you don't know, right? And ignorance is bliss. So you'll just continue to do the thing you're doing because you think it's correct. And, we can look at some very clear, defined examples of that in our world, in the medical fraternity. For a very long time, and I'm sure you probably did it, every patient got high flow oxygen regardless of how unwell they were. Well, we know that, just because oxygen is good doesn't mean more oxygen is better some of the time. And we needed to come to that conclusion. We talk about fluids, the use of saline in trauma patients. We just used to assume that as long as they had a good blood pressure, everything was golden. Well, we know that that has nothing to do really with perfusion. So there's a problem there. We needed to change that mindset. One of my old favorites is the the use of ice on soft tissue injuries and that little bad boy, we know that that was in fact possibly and probably is quite detrimental in a lot of areas. Well, if we didn't take the chance to look at those things and then adapt and change our mindset around them, then we'll just continue to do them. And unfortunately, in our world, some of those paradigms are incredibly entrenched and they are difficult to shift. Now, I've just given some very like small kind of clinical examples, but probably the biggest and bigger problems are around those systems that we're locked into, those concepts that in order for you to be good at something, you experience is equals. This is a good one. Experience equals expertise. The whole 10,000 hour thing and blah blah blah. It's not true. If I teach you to tie your shoelace wrong and you practice it 10,000 times, it's still wrong. You're just really, really good at being wrong. And so it's more than just experience. It's more than just the thing you do. It's how well you do it. Can it be optimized? And we need to continually be looking at what we do, particularly in the environment in which we operate, because it is so fluid. Is there a better way to do things? And in fact, one of my favorite sayings and I know I brought this up in a previous chat with you around a book called Legacy. One of my favorite sayings there is when you're at the top of your game, change your game. Because if you think you're at the top, then there is only one way, and that's down, all right? But unfortunately, when you're at the top, you're probably not at the top at all. So change your game, look for another summit and try and go there. And if you use that as a mindset, if you're always constantly going, well, there is no perfect, there is no summit, there is just the process, then that will allow you to constantly be able to bring in new information, filter information, own the fact that you've been doing things probably wrong. I have to put my hand up. In the couple of decades or more that I've been doing this stuff, I've definitely done things that were now not great, and probably in many cases detrimental to patients. We did them because we thought they were the right thing to do. If I didn't now change my practice when I know that they were wrong, now that's on me. So that's that mindset shift.
Definitely. No, absolutely. Absolutely. Let's pivot slightly, Andy, and look at really the concept of stress inoculation and performance conditioning.
Mm.
We talk about this concept of graded exposure, and well, I guess in a way, you don't have control of the critical care situation as far as, the situation is the incident is the incident, and the graded exposure is almost the manifestation or the embodiment of leadership and starting to give a trainee or indeed a student more leadership, more say, more essentially center staging them more, but doing that through a mentorship. So that this is maybe how you move, how you act, how you communicate, and then start to in a graded exposure way give them more of a center stage of leadership so that they can start to understand how to move within that stress so that they are becoming progressively more inoculated. Could I get you to speak to, and certainly that was my experience of critical care was, someone else is driving the vehicle, someone else is in control of the scene, but slowly but surely I'm starting to step forward, starting to understand what the scene needs more, starting to understand what the team needs more, and really starting to cleave those 1%. But could I get you to speak to your thoughts on that?
Yeah, there's an interesting space around this concept of decision making, isn't there? So, like, because that's really a lot of what we're talking about. Because as you become um, more experienced, as you become have a greater level of expertise, there's a shift in the quality of your decision making. At least you would hope there was. So what is that? I was lucky enough a couple of years ago to be involved with some really interesting research that utilized physiological tracking using a thing called hexoskin suits, which is basically just a Fitbit on steroids. It measures all sorts of cool stuff. And also using glasses that have eye tracking. So that eye tracking measures things like pupil dilation, direction of sight, how long you gaze, and all that sort of stuff. And we were putting operators through high fidelity, high stress simulations, and we were seeing a correlation between their stress and their decision making, and also a correlation between where they were looking and for how long. So here's a question, a little bit of a fundamental. Do you think that when a novice and an expert walk into the same room together, who sees the most? Who sees the most?
Yeah, that's an interesting question. I would say it would be you'd think it was hopefully the expert, but maybe not, maybe not. Maybe it's the novice because they haven't seen any of that before.
It's an interesting one. So what we found was that what the expert does, and you would this is this idea of building heuristics, right? These scripts that we learn about things, was that they will scan a room very quickly and they will start to pare away variables really fast. Because what is a decision? A decision at the end of the day is nothing more than the paring away of variables down to one. And that one is the decision, right? Now, if there's only two variables, left and right, and you pair one away, then you go right. Or if you pair, yeah. Now, what we found was that, and this is backed up in quite a bit of other literature, is that the experts will walk in, they'll scan the room, and they'll very quickly be able to go, I don't need that, 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 da, 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 boom, decision. All right. Now, is it always going to be the correct decision? Not always, but it's more likely to be. The novice comes in and looks at something and then looks back at something else, but then goes back and looks at the other thing again, goes, I don't know if that's important. I don't know if that's important. I don't know if that's important. Oh, no, 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 no. Now, eventually over time, they will pare things away, and eventually over time, they will come to a decision. That decision may be the same decision that's been made by the expert, or it may be a different one if they went down a different path, but it will have taken them longer to get there because they've had to go through a whole lot more decision-making variables to get to the same point. So when we start to think about how we're going to get people to become inoculated, what we need to do is ensure that they are becoming acutely aware of their environment and the way that they're responding to that environment. And what we saw in a lot of these operators was that we could see their physiological response starting to grow. What that would then do was it would cause them to become less certain of their decision making, which we were seeing in their eye tracking, and then they were more likely to make a mistake. So what was really interesting is we were able to map ahead of time. We were literally watching them on screens as they were going through these things and go, that person's about to make a mistake. And then 10 seconds later, they did. Now, that's pretty cool stuff. What it means to us is that we can then take that information, bring it back to the operator and go, hey, did you realize that when you are in this type of situation, you become less certain? Why? And I'll use an example. There was a number of the operators had only a limited amount of training in needle decompression for tension pneumothorax, right? They had the skill, but they weren't confident in it. And when they were presented with a particular patient that required that thing in a high fidelity simulation, they were under the pump, they became uncertain about their own ability to manage like landmark properly, etc. And they were far less. So we saw their eye tracking go all over the place. We saw their physiological response go through the roof, and they failed. More often than not, they failed the skill, right? And so what we were able to then say to them is we now know where your failure is. Let's get you better at that thing, all right? And then you are less likely to make a mistake in that same situation. That's inoculation. So discovering the things that you need and then going back to them, that's the key. Because human nature is a funny thing. We will always want to perform well, right? So are you left or right-handed? Are you left or right-handed?
Right. Yeah, right-handed. Yeah.
Okay. Okay. I'm left-handed, so I won't hold that against you, but that's okay. So if I threw a ball to you and asked you to throw it back to me, you would throw it unless I specifically told you otherwise. You would throw it to me with your right hand.
Yeah, absolutely. Absolutely.
Why? Why?
I think you're right. It's an ingrained habitual practice. So it's one of these things. And to your point, I don't even think about it. It's a subconscious motoric movement. I receive a ball and I don't even put any effort into it. It just is ingrained.
You just throw it, right, with the right hand because that's the thing you're good at. That's the thing you're good with, right? That right hand. And yet, you hear this in elite sport. If they're going to be an elite soccer player, they can't only be able to kick with one foot. They have to be able to kick off both feet. If you're going to be an elite level rugby player, you have to be able to pass in both directions. There's no point in only being a uni passer. If you can only pass left, you're no good to anybody. All right. So what do those level of people do? They practice the thing that they're not good at. But what do humans innately never do? They don't practice the thing they're not good at. Why? Because you're not good at it. And so we have to be told that, and you have to consciously make the effort to work on the thing that you're not good at. And that's the type of thing we can use because once we can become aware of something like a stress response, then we can work on the thing. But until you're aware of it, until you work on it, if you change nothing, nothing changes.
Yeah, listen, that's powerful. I think that's powerful. And in essence, what you're saying there is, and I absolutely agree with this, it's becoming an expert or indeed, far more advanced in your practice, certainly on a stressful scene. It's the process of inhibition, and what you're right, it's paring away information to get to the signal versus the noise. So being able to really discern the signal, it might be the soiled airway in a million things which are going on right there, and you can just dial in on the soiled airway, and it's that fundamental thing of the corpus callosum between left and right brain. Actually, what it does, it's a process of inhibition. It doesn't completely overwhelm both sides of the brain with information. You discern and triage what's important, and the quicker you can do that, in a way, the more mastery you have over the scene, certainly in critical care.
Yeah, exactly. And then we see this a lot. Like, remember back when you were like, fresh faced and that newbie, and you walked up to the front of a house, and you could hear it's 3 o'clock in the morning. You've been called to a 3-year-old at 3 o'clock in the morning. It's cold, it's dark, and from the front door you hear a barking seal-like cough. Now, when you're a newbie, you're just like you're primed, you're stressed. It's 3 o'clock in the morning. You're going to a sick kid, and nobody likes going to sick kids because they're scary. But you look over to the left, and there's your mentor, your partner who's experienced this, and they look calm and collected. All right, and you walk into the house, and you as the newbie go up, and you see this kid, and you introduce yourself, and you try and go through all of your assessments, and you're very thorough and everything else, and you do your auscultation. It's very clear, and then you think, you know what? I think I know what this is. I believe this is croup. And you turn to your partner, and they've already got the nebulized adrenaline ready to go, and they've been waiting calmly waiting for you to come to this conclusion, and they've been waiting for 5 minutes. And when you go, hey, I think it's croup, and they're like, yeah, I know. And then you're like, but how did you know? And how come you're so calm? And how come I'm now so cognitively loaded because I'm running all of these scripts in my head to try and come to a thing, and you've already got the solution. Well, what is that? That's that ongoing training. That's that level of expertise. That sometimes that's just something that you need to develop over time, but you also need to develop it over time in the right environment. So if you weren't taught the right way, if you weren't given the right mentoring, if you're not supported in the right way, then you might continue to misdiagnose that child or mistreat that child in terms of your management. So that's the role of that mentor then, is to show you that yes, you are on the right track. And over time, now if you went to that kid, you would have already diagnosed that kid from the front door when you first heard the barking seal-like cough because it's 3 o'clock in the morning, because it fits the script. That's not to say you're not going to discount any other differential diagnoses, because that's dangerous, but you certainly got a pretty good idea before you walk in the door, and that reduces your cognitive load. If it reduces your cognitive load, it can also then reduce your stress because you're aware of it.
So let's talk about cognitive practice within the domain of deliberate practice.
Mm.
So yeah, let's just unpack deliberate practice actually, Andy, for a minute. And in a way, could I get you to really just unpack what deliberate practice means to you, and indeed how you train within the domain of deliberate practice within WA?
Practice for the sake of practice is not only not going to help, in fact, it's probably going to be detrimental. If you practice something poorly, you'll perform poorly. There's that old adage. That's a very, it's kind of an old system thinking. But it's true in the sense that if you don't prepare to play the way that you will be playing in the real thing, then you will not be prepared for when it happens. And so, one of the most dangerous things you can do is poor quality practice. In fact, I'm going to say that in many cases, poor quality practice is more detrimental than almost no practice at all because you're learning poor skills, poor systems, and those things then become entrenched. Those become those fixed mindsets that you need to then try and unravel and change later on. So when you are going about your practice, it needs to have a couple of things to consider, and this is something that we're really trying to start to drill into to our clinical leads and then out through the rest of our clinical thing is you need to be comfortable um, and train to succeed, but be prepared to fail. And in fact, it goes back to Gilbert Anoka's concept of training messy. It's okay to fail. In fact, it's not even okay to fail. We want you to fail because I don't know about you, mate, but in the thousands of jobs and patients I've seen over the years, I'm yet to do the perfect job. I've never pulled it off. I don't think it's possible. I don't think it can be done. So I'm preparing, and we should be preparing for something will always not go correct. Something can always be better. And that's the way we need to train. We need to practice. That's that deliberate concept. We also want to have this idea that when we're practicing, we should be always building in feedback mechanisms. Those feedback mechanisms should be innate because if they're not, then we will miss the point. We will miss those learning opportunities. Some of those feedback mechanisms may be extrinsic. It might be the feedback of a partner. It might be some kind of like formal debriefing or etc. But a lot of it will be our internal, our intrinsic feedback mechanisms. How did I feel when I did that thing? How did that interaction with that person feel? How did that skill feel when I did it? You talked before about a soiled airway. When I was clearing that soiled airway, how did I go? When I was suctioning, did I feel comfortable with that? When I was using the laryngoscope, how was my technique? All of those sorts of things need to be considered, and you need to provide feedback both to yourself and to others in it. If you don't do that, then you will just continue to do the thing you're doing, assuming again that you're doing it correctly or you're doing it as well as you can be. And more often than not, you're wrong. So for us, deliberate practice is it's creating an environment where people feel safe enough to fail and that it's okay, in fact, to fail to succeed. And if you do that, then what you're probably going to end up is in an environment where people are okay with like trying things that maybe they haven't done before or trying them in a way they haven't done them before, looking for that magic thing, that optimization, which, to be honest, again, it's the pot of gold at the end of the rainbow. It's the continuum. It's the thing you're aiming for, but you're never going to actually reach. That's where we're going with our deliberate practice. And from my mind, a lot of it comes down to ensuring that the people that are managing and educating and leading provide an environment for that to occur.
Yeah, absolutely. And I agree with that because I think the fundamental tenet there is one of feedback and actually receiving feedback to your point around it doesn't matter really if you succeed or indeed fail within training because essentially there is you just need to be open to feedback or multi-channel feedback, the feedback through deliberate practice, the feedback through debrief, the feedback through just having a peer support system where you might have a ride out shift with a peer and actually say, look, speak to my practice, good or bad, just but being open to feedback and not you learning to change the valence. Like you said, it's not about being negative. It's really about learning together, reshaping learning to bring about a predefined outcome.
It's really interesting that you mentioned that term negative because more often than not, I've talked about this is that negative is feedback is coined in the terms of either being positive or negative feedback. I don't think those are accurate terms. To me, constructive and destructive are more accurate terms because you can have negative feedback that is constructive. Because if I say to you, "Hey, look, that cannulation wasn't particularly good, but this is why it wasn't good. And so this is a way for you to improve to the future." That's negative in the sense that you failed or didn't do as well as you could have, but it's constructive because you now have a way forward, a process and a solution to make it better. Likewise, just being positive doesn't make it constructive. I can say, gee, you're the most wonderful person in the entire world. Now, other than feeling a little bit good about yourself, it doesn't mean anything, and you don't learn anything. So I think let's get away from positive and negative as just those two terms on their own, and let's talk about constructive and destructive.
Yeah, indeed. No, indeed, indeed. Let's just pivot slightly, Andy, mindful of time, but just a couple really more fundamental concepts, really. One is around threat versus challenge mindsets. And indeed, how, as clinical educators, we can really, I guess, in a way, help teams and individuals reshape stressful events to your point, just to really see it as informative, and to enhance performance rather than denigrate it. So how can we just really reframe adverse, not necessarily adverse events, but suboptimal events to really reframe them so like you said, it's challenging and it's informing our practice. Like you said, I love the concept of winning messy, because actually you're still winning, and there's always learning to be had. But could I get you to that pivot around sort of reframing threat versus challenge, and how we can sort of
Mm.
reframe stressful events?
Mm. There's a big body of work, well, it's a growing body of work around this concept of operational cognitive readiness. I don't know if you've kind of delved into that space too much, but there's some really good work in that space. And really, what it is it's not an individual or one specific thing. It's a series of different concepts and skills that come together to improve a group or an individual's ability to operate and be ready for particular things. And a real cornerstone of that is this concept of threat versus challenge. So we know that if we go back to sort of the start of this conversation, we talked about, sympathetic response, and we talked about that jacked heart rate and that sort of, diaphoresis, and that we know that we will see a runaway kind of thought process start to occur. We will start to see cognitive load start to really pile on. Well, you spoke earlier about the ability to not manage, well, you have only a finite ability to manage input coming in and therefore process. So when we see something as a threat, we are wired to go into a sympathetic response. It's how we've developed. It's an evolutionary thing, and so we will then have these other responses. Now, why them themselves are not a negative, we have to have them, and we spoke about that. You have to have some level of sympathetic response. What the difference is that how it transfers over to our cognitive load, and then how that cognitive load transfers over to our ability to make decisions and the quality of that decision making. So if we are able to reframe the thing we are looking at, it's a matter of perception. It's the same thing, right? You and I could walk into the same room, look at the same thing, and because we have a different perception of it, you might see it as a challenge and I might see it as a threat. Therefore, I'm going to have a different response to you. All right. And that's okay, except in our world, in our environment, when we perceive too many things as a threat, or we fail to recognize that something isn't as a threat, but rather something that we can then leverage as say, a challenge, and I'll get to that in a minute, then we will cause or have this sympathetic response. We will get this cognitive load pile on, and we will see a decrease in the quality of our decision making. So by looking and being able to think about perspective, and that's what this is. When I look at something, let's say it's a scene, as I walk into the scene, as I survey that scene, and I'm using my situational awareness, and now we're not, starting to use our bigger set of tools around our human factors and non-technical skills. I'm able to utilize some of the other understanding that I have of, like, say, the environment. Let's say it's a motor vehicle accident. I'm able to survey that scene. I'm able to take a quick look at it. There's no burning. People are out of the car. They're walking around. There's no one entrapped. I'm looking at the airbags. I'm taking in all of that information. As long as I'm able to perceive those things and process them in a way that allows me to think about them in a more objective manner, then I will allow myself to be able to back off on the cognitive load, and I'll be able to slow all of that sympathetic response down. And therefore, hopefully, and remember, this is all, how long is a piece of string? By reducing that cognitive load, we'll also be able to improve the quality of our decision making.
Yeah, absolutely, and I agree with that. I think, they say slow is smooth, smooth is fast, and
It's
it's a
fast. Yeah.
real cliche, but it's actually absolutely true.
Yeah.
Slowing yourself down, B, slowing the team down to a place where you can start to make good, methodical decisions, and just, but to your point, just get some clarity on the priority. Get some visibility on, the next best thing to do, and then also just delegate to the team. Am I missing anything? So again, verbalizing to the team, so almost overtly expressing what's in your mind, so no one's guessing what's in your mind. So sharing the mental model, as I guess we could call it, but then delegating to the team, and then executing on the next priority. And yeah, I just want to pivot slightly and look at really an example, because like you said, a lot of these are concepts and a lot of them are fascinating to listen to, but they only really come to life when you put flesh and bones around them. Could I get you to speak to really yeah, an example really from your own life where you have in a way pivoted into you've mitigated stress, and or recognized it in yourself, and really managed stress within a team, or not? I mean, to your point, it's as informative when you've maybe realized that, oh gosh, maybe I fell over in that circumstance, and became overwhelmed and didn't delegate early enough. But could I get you to speak to maybe just a reflection from your own practice which was informative to you?
Yeah, I'm gonna use one where I most definitely failed, at least initially in my decision making. I went to a motor vehicle accident. The car had gone off a bank, rolled, and was on its roof. The patient was entrapped. He was still in situ with the seatbelt on. The fireys on scene were doing their best to try and to mitigate it. Um, One of the windows was broken, and they deemed it safe for me to enter through that window. So I did so. So the patient is upside down, and I'm in the car. He had a significantly reduced GCS, which we later found was actually not a head injury, but rather he had had a hypoglycemic incident, and that's why he'd driven the car. So these are these things, right? You don't always. It's not always how it seems. Um, and I don't know. I was early in my career. I had, a bunch of new skills, and I wanted to use them. This guy was, and I was like, oh well, he's upside down, and he's going to need some pain relief, and he's probably going to need some fluids, and blah 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 blah. So I'm going to cannulate him. Now he was upside down, so that meant that I was now trying to cannulate a patient upside down, back to front, in a car, in the dark, in a ditch, in the middle of the night. And I was in the middle of this kind of setting up for this cannula, and this very, very senior clinician popped his head in the window and goes, "What are you doing?" And I'm like, "Well, I'm just setting up for this cannula." And he's like, "And what are you going to put through it?" And I was like, "Well, I don't know, but when I need it, I'll be." And he goes, "Get out of the car, man." All right. So like I was like, it was just a very, very, very valuable piece of learning, and it really stuck with me that I had just become task focused. I had become very, very narrow focused in terms of like what I thought was the right thing to do, and had then become blind to the fact that we just needed to get the guy out of the car so we could manage him appropriately. He was still conscious, he was still maintaining an airway, etc. So at that point, we had a little bit of room to move to get him out. So that stuck with me because it made me really question my own quality of decision making up till that point, particularly in your career. Sometimes the arrogance of youth is a beautiful thing, and sometimes it is most definitely not. And it was that whole concept of like, gee, I just thought I was doing the right thing because it was a thing to do. So what I did then was, and this was one of the things that kind of set me off on my path of like learning about the stuff we've been discussing today and how to mitigate and manage stress, and then how, therefore, to improve the quality of decision making. And the biggest thing that I came to the conclusion of after sort of debriefing myself over that was it was the feedback from my partner telling me all he needed to say was, "What are you doing, man?" And it broke the spell, right? And so that was that feedback. And then I realized, okay, this is something that we really need to drill into. We need to be safe. We need to feel comfortable with telling each other in these environments, hey, or asking questions of others, and then also being asked questions yourself without being upset about the fact that someone's saying to you, "Hey man, why are you doing that?" You know, and instead of throwing your toys out of the cot and just saying, "Well, I'm doing it because it's the cool thing to do," you say, "Well, actually, you're right. It wasn't the right thing to do, and I need to get out of this car." So, yeah, I don't know. That's a little example. I've probably got thousands more of those.
Listen, no, it's powerful. It's powerful because, like you said, we learn far much more through those types of incidents than we do from otherwise. You were just talking there, and I was picturing being in that car, and I've had 1,000 myself where I've like, what am I doing? What am I
Yeah.
doing? And just feeling completely, like you say, sucked into it, sucked to absolutely task overloaded, and but just you need someone else just to really drag you out of that situation, just to question it.
I saw a beautiful example of this in reverse at a job recently where one of our guys was dealing with a very difficult airway, and he recognized the fact that he recognized the fact that he had become task focused on the airway, and he handed over leadership of the scene because he goes, "I am totally cognitively loaded right now. I need to focus on this. Can you take over?" It was a beautiful piece of work to see. And the scene was very well managed, and the airway was extremely well managed. Everybody wins, right? So the patient ended up with better care.
Yeah,
So,
absolutely. And that's the pivot. It's just understanding when you're going to become task loaded or maybe overloaded, and you actually just need to delegate and step back in and step out. And absolutely, it's a dance, and it's a real art form that's refined over time. Andy, just as we finish off, I'm mindful of time. It's really this, I mean, and this is fascinating to me because it is a real art form. And I think that the concepts of leadership that we spoke about in the last podcast is iterative over time. Yeah, and it isn't about learning lists in out of textbooks anymore, because like you said, when you're training leaders within critical care mindsets or otherwise in leadership within healthcare, it's beyond the kind of the rote understanding of it. It's this subtle art of like you said, knowing yourself, knowing when to step in and out, learning these concepts, learning to embody them, but also delegate to the team. And all this takes time, deliberate practice. But could I get you to speak to? And it's hard to really ask for, in a way, sort of a top three action points, because there's so much more deeply nuanced than this. But if there was some top of mind action points for educators and clinical leaders, Andy, that want to leverage, in a way, just some of these learnings, and indeed just maybe just from a conceptual basis, how to best embed them within a leadership team. Could I get you to speak to that?
yeah, I think one of them is we need to most assessment tasks, most education and then assessment tasks tend to focus on things that are tangible. So in our world, that means that the things that are most often assessed are things like hard technical skills. Can you put in this cannula? Can you do this 12 lead ECG? Can you interpret the squiggly line? Can you draw up the drug? Can you put in the tube? Right? Why? Because they're measurable. They're easy to measure. You can see success or failure. Did the tube go in correctly or did it not? All right, it's pretty clear. And so a lot of our education has been very firmly entrenched and focused on that because it's easy to then measure and assess, right? What's far more difficult to measure and assess is all of those other less tangible, non-technical human factors type skills like situational awareness, critical thinking, clinical decision making, the ability to communicate effectively, and the like. Those are very difficult to measure and therefore difficult to assess because then, you can't say they passed or failed. And I have a real problem with pass fail. I have a real problem with competent, not competent, because they do set this very defined line between whether or not the tube went into like, this level and that went into that level. That's not going to be, in most cases, the determining factor of whether or not a patient is managed well, a scene is managed well, that you're going to get the best patient outcomes. The determining factors of those scenes, and you will have seen this yourself, mate, in Heames and stuff, is that it's the ability of the different members of the crew to communicate with each other at the appropriate time. It's that one person has the ability to be able to contain, like just hold situational awareness, hold that 360 view, and ensure that everybody's got forward momentum and that you're not spinning your wheels. now what we haven't done traditionally is created both education systems and packages, and then conversely, measurement or assessment tasks and tools to measure those things because it's hard to do. But that doesn't mean we shouldn't be doing it. It can be done and it should be done. And that should be the focus for us moving forward in this clinical space. So it means educating our educators better. It means moving away from a pass-fail mindset, from a competent, not competent mindset. It means moving towards things like making people aware of the things that are most important in the scene that they are managing. With some recent assessments that we ran to bring on some new clinical leads within our organisation, 2/3 of the marks within their very substantial SIMEXs were non-technical human factors skills. And we intentionally put in those SIMEXs multiple levels of clinicians for them both to be working with and handing over to. We were looking at things like the quality of their handover, the quality of their communication when they were doing consults on phones, the quality of their communication when they were dealing with family members of the actual patient. So the patient needed, arterial tourniquets and a chest needle decompression and a light. Okay, there's your technical skills. We can see all that happening. But there was a subtle thing in the background of, well, what about the mum? Are you dealing with the mum, or are you dealing with how's that? What's that language sound like? Do you have the ability to be able to have the nuanced ability to say, change your language from when you're dealing with the mother to when you're dealing with a consultant at handover in the hospital, because they're not the same. And so those were all now form a part of our assessment, moved away from competent, not competent, have a whole completely different scale. It's a continuum of assessment and pass, and that is somewhere there I think, we need to go more broadly in our space in order for us to really get people to start looking at the things that are most important and will have the greatest impact on the outcomes for our patients.
Listen, that's powerful, Andy. And to your point, it's a sliding scale. It's far much more deeply nuanced. It's difficult and challenging, but it's absolutely necessary. Listen, it's always a pleasure to talk to you. It's fantastic to get your received wisdom on this concept, and hopefully we'll have you on the podcast again. It's been an absolute pleasure, Andy. Thank you so much.
Oh, thanks very much, mate. I really do appreciate it. Enjoy the chats.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.